Now it's my pleasant duty to introduce, he doesn't require any introduction at all, Professor Srinivas Murthy sir. And he is a national EC member RSSDA and involved in many international and multicentric trials. He is going to talk about drug, diet and obesity approach in type 2 diabetes. Very practical session this will be, very interesting for the clinicians. Thank you.
Thank you, sir. Good morning and வணக்கம் தமிழகமே. Shanmugel sarke, Murli, Balaji, Chandru, and above all Anand Moses sir. Thank you, and of course the star JVK sir. We were missing him in the national forum from some time, so hope you will come back. கூப்பிட்டதுக்கு நன்றி. இது வந்து diet, drug and diabetes. This is what I'm supposed to be talking about, and I'm sure this topic would be given by Shanmugel sir only. It's a modern epidemic, we know. It's linked with various pathophysiological mechanisms which revolves around the insulin-resistant and hyperinsulinemia. And it was first coined by Sims et al. I think we should remember the great people who have invented and coined it also. We know the diabetes epidemic in our country, 9 out of 10 people with diabetes are overweight or obese, and 1 out of 3 Indians are overweight, have diabetes. And this is the burden we have today in our routine clinical practice. And of course, we know the greater the weight, the greater the risk to develop diabetes, and that is to the tune of 22 times. And of course, visceral fat, just to talk about Balaji's earlier lecture was alluding about the triple G and the double G, where the dangerous fat is the visceral fat. That is what you have to remember, and about 200 odd diseases have been attributed to that. And this is the pathophysiological link regarding the crosstalk between the obesity and diabetes. Basically, the inflammatory, the adipokines versus insulin resistance eventually would result in endothelial dysfunction and the micro and macrovascular complications. Now, we know with every 1 unit of rise in the BMI, the probability of developing being a diabetic increases by about 1.5%. And this is in individuals without diabetes, it's 0.5%, whereas with diabetes, it's about 1.5%. And there is a greater risk of developing this diabetes with a higher BMI, both in women it is more, and of course in men also. This is a prospective cohort study which showed the relationship between the BMI and the risk of developing in about 1 lakh odd patients. Now, why is weight reduction is important? Because we know the weight reduction improves the insulin sensitivity, preserves the beta cell functions, and to achieve beneficial effects on the glycemic control, as low as 5% weight loss is enough. And for each kg of weight loss, there is an A1C reduction proportional to about 0.1 point. And that's very, very important. And the balancing this glycemic control and the obesity risk is a challenge in routine clinical practice, and for which we have some of the anti-diabetic medicines which add to the fuel which are related to the weight gain. And of course, weight reduction improves the diabetes control, which is proven way beyond. The greater the weight loss, the greater the reduction in the A1C and the fasting blood sugar. Of course, weight loss reduces the diabetes risk over 10 years. And this is a diabetes prevention DPP program where about 3,000 subjects with pre-diabetes were randomized into 2 groups, intensive, and of course, the intensive participants achieved about 7% weight loss. And the more important, you should see the light blue color, and that is your lifestyle changes, which most of us fail to implement or to incorporate into our patient's lifestyle. The lifestyle modification can bring down the A1C to the tune of above 1%, and which many drugs will fail to reach that stage, but this is the healthy lifestyle which can give rise to that, and that is something which we should spend little time with our patients to do that. And of course, weight reduction leads to diabetes remission. This is one of the very famous trial called DIRECT, where the weight management program with the best standard of care, they saw that the greater weight loss led to the greater proportion of patients achieving and maintaining the remission, that is about 1.25 odds ratio with the diabetes remission at the end of 2 years for every kg weight loss. And that's something very important. There are various benefits of weight loss in people with diabetes and obesity. And of course, as you can see, it can manifest with the reduction and the improvement in the lipid profile, the sleep quality, proteinuria, albuminuria, hyperglycemia and remission, CV mortality, and of course, even the blood pressure. This is a look-at study which showed that 10% weight loss can have a 21% lower risk of composite outcomes in 1 year of time. And it's primary and secondary outcomes. Both are statistically significant numbers. And of course, you can also have the beneficial effects on the blood pressure, the TG and HDL and LDL also. So the loss of as low as 5% body weight in the year following diabetes diagnosis was associated with the improvements in the risk factors and 48% lower hazard at the end of 10 years. Now, this is very important slide to talk about what are the advantages you get with the percentage of weight loss. You can see there 5% can help with hypertension, hyperglycemia, 5 to 10 with the prevention of diabetes, NAFLD, PCOS, dyslipidemia, and 10 to 15% CV disease, urinary stress incontinence, NASH, etc. More than 15% for sure, diabetes remission, CV mortality, and FPEF also you get advantages with that. But the problem is, this is the normal people who lose weight, but people with diabetes lose less weight. And these are the various problems associated with the diabetes, where the sedentary lifestyle, the reduction in the glycosuria, stress burden of diabetes, fear of hypoglycemia, binge eating, compensatory eating, and of course, various medications which can cause weight gain. To tackle this, we've been having these dietary recommendations. You can see the history of these dietary recommendations, where the low-fat diet popularly was introduced, then the food pyramid was introduced, then the My Plate was introduced, and of late it is the Mediterranean, vegetarian, and the DASH diet which has been done. And of course, WHO clearly recommends the intake of the carbs should be primarily from the whole grains and vegetables, fruits, and pulses. And the strong recommendations you can see on the left-hand side, and the conditional recommendations for children also, it has been clearly given. The dietary guidelines recommends that the carbs should be about 45 to 65% of the total daily calorie intakes. And this is all the various diets which are available, and the advantages we have just outlined on the right-hand side, where with these various diets we can attribute the advantages. Just to talk about few words about the low-carb diet, that's called LCD. ADA defines the LCD as a daily consumption of 25 to 45. Just to remember, 25 to 45% of the total calories from carb sources, and while consuming less than 26% is called as a very low carb diet. And the VLC dietary goal would be to induce nutritional ketosis, and the LCD allows approximately 150 grams of carbs per day. Usually ketogenic diet prescribed allow only 20 to 40. That is the keto diet which already going off now. The more restrictive diets allow only less than 20 grams of non-fiber carbs per day. And this ketosis, which is nutritional ketosis, curbs the appetite in the form of nausea, vomiting, fullness, the increased acid load that can aggravate the bone loss and deficiency of various other nutrients. These are the merits and pitfalls about the low-carb diet. We know the merits, but the pitfalls would be it eliminates certain nutritious food items. It may be associated with a higher risk of mortality and a longer duration. Ketosis associated with the halitosis, which is again a problem, and nausea, vomiting, which is again a blessing in disguise as a side effect for many morbid obesity patients. And curbing carbs with the soluble, insoluble fibers, and this is a relationship to show that the U-shaped association is seen in these two studies, where the overlapping and continuous relationship, you can see the safe limit would be about 40 to 60%, above or below, both can give rise to the all-cause mortality benefits are waned off. This is what I was talking about. The long-term LCD, the NHANS study suggested that a positive association between the long-term LCD and the risk of stroke mortality. Now, this is how you need to manage the obesity in general. The first thing is about the lifestyle interventions in the form of diet and physical activity, which I showed you in the direct trial, the advantages of the lifestyle changes. Pharmacotherapy, metabolic surgery are the other options, and invariably most of the patients end up with the pharmacotherapy. Based on the BMI categories, the weight loss management should be categorized, and of course high frequency counseling, behavioral strategy, nutritional plan that can create an energy deficit regardless of the macronutrient composition. Nutrition supplements have to be taken care. And in diabetes and overweight or obesity, the preferred pharmacotherapy should be SGLT2s and GLP or GIP and GLP combinations. And the weight loss medications are effective as an adjunct to diet and physical activity. Please remember that. And of course, behavior counseling plays a very important role when the patient has to continue for a long therapy. And of course, the response to the weight loss medication, you need to figure out in about 3 months. If there is no loss of less than 5%, then it is a failure. Then it may not give you the advantages when the early response is insufficient in such patients where the weight loss is less than 5% in 3 months, and consider discontinuation of the medication and evaluate alternate medications or treatment approaches. These are all the various nutritional management of obesity used in the practice, various diets. The low GI, high fiber content is something which is recommended in general, and that is what will help our patients. Of course, we do face challenges whenever there is a lifestyle intervention, because most of our patients, and because of our cultural problems, we end up not following this lifestyle intervention consistently. So 8 out of 10 patients require additional interventions apart from the lifestyle. 50% of the patients return to starting weight the starting weight within 5 years after starting the lifestyle modification. And of course, people on lifestyle modification can gain up to 35% of their lost weight in just 1 year. And that's the bad thing about this lifestyle intervention. And of course, the progression of diabetes with different interventions, you can see in this study, those who attained the NGR at least once during the DPP compared to those who consistently had pre-diabetes stratified by the treatment groups. And this is where you have the lifestyle, pre-diabetes, lifestyle, metformin in pre-diabetics, all that. And the pharmacotherapy, in addition to diet and exercise, can help our patients to achieve the clinically relevant weight loss. That's something very important. And this trial assessed the efficacy and safety of once weekly subcutaneous semaglutide, which is not available in our country, though for trials we did use. But this is something which is shown in this. So in people living with diabetes or overweight, we need to minimize the medication load, prioritize the medications with beneficial effects, and consider the anti-obesity medications along with the lifestyle intervention, and based on the risks and benefits, prefer GLP-1s or the dual agonists, and re-evaluate regularly and intensify the treatment. So these are all the effect of anti-diabetic medications on the body weight, the GLP-1s, SGLT2, metformin, and DPP-4 alpha glucosidase inhibitors, AGIs, are weight neutral, and insulin, sulfonylureas, meglitine, TZDs are the groups which you should think about. And of course, the guidelines now have gone to the tune of recommending these drugs at the baseline. With the very high efficacy, you can see the semaglutide injectable and the tirzepatide, and then the high efficacy is dulaglutide, liraglutide, and intermediate is, of course, the SGLT2, and neutral they were mentioned clearly. This is the ACE guideline, which talks about the anti-obesity medications, which has to be considered in people with diabetes, living with diabetes, and these are all the effects, how these cause weight loss, and the advantages with the CV benefits. You should look at the SGLT2 and the GLP-1s. And this is the GLP-1 RA and semaglutide, which has got the CV and metabolic effects, which are beneficial to the pleiotropic benefits, and this is how the GLP-1s act upon. And of course, Balaji covered these topics. The GLP-1 RAs harness the effect of GLP-1 for therapeutic use, both in the obesity and diabetes. And the oral tablet and the injectable liraglutide is available. And of course, dulaglutide is not recommended as anti-obesity. These are some evidences to show that the weight loss is efficacious and it is sustained over a period of time. These are subjects on semaglutide 2.4 mg once weekly achieved with the weight loss goal. The STEP trials, which are talked about, and the improved glycemia. 7 out of 10 achieved less than 6.5% of the A1C. 8 out of 10 achieved A1C of less than 6.5% as well. And these are all the cardiometabolic markers, which are the ASCVD risk factors, so-called, are reduced with this. And of course, significant reduction in proportion of subjects with prediabetes also has got a role with semaglutide. And tirzepatide is a dual agonist, which is a novel ligand with agonist activity for both GIP and GLP. And the GIP targets the white adipose tissue, which is very important for us, and the GIP component of dual GLP and GIP receptor agonist. And this, you can see on the right-hand side, the effects of GLP and the GIP. For want of time, I'll skip. These programs were called SURPASS, which is basically to demonstrate the tirzepatide 10 mg, 15 mg weekly once for non-inferior to sema, 1 mg once weekly for mean change of A1C. These are all the trials which showed that it is non-inferior and superior to semaglutide whenever it comes to the tirzepatide. Definitely it scored over. And SURMOUNT-2, we were part of the SURMOUNT-2 trial, where about 23 subjects were recruited from our center out of 29 from India. And in trial and on treatment, this is beyond also, they overlapped with a real world kind of a study after the study was closed out. And the GI side effects, of course, there are mild to moderate. The diarrhea, the GI, upper bloating, vomiting, nausea are some of the troublesome. And there were no withdrawals because of the severe GI effects also. And Carglutamide, semaglutide combination, Cargisema, we are doing Reimagine 2 study now, which is ongoing, which is again amylin derivative, again for weight loss and in diabetes we are looking at once weekly. This is a combination of Carglutamide and semaglutide. And the Cargisema appears to have a safe and well-tolerated profile in phase 2 and phase 1 studies are already there, and phase 3B we are doing it now. And these are all just to talk about the anti-obesity medications approved by the FDA, and technically we are just using Orlistat occasionally. Now the GLP-1s, SGLT2s, we are using it, though SGLT2 are not indicated, but this is the liraglutide and the Orlistat, which we are showing the comparison. And of course the other drugs we hardly use, and they have this prevention of diabetes complications advantages, and with the risk of complications comes down, which can be in the form of BP control or the lipid control. And this is the retatrutide, which we are again doing a study called TRUMP-2, which is once weekly injectable triple hormone, where this is targeting basically about the hepatic liver metabolism, which is the glucagon receptors are there, and the weight loss mechanism may be complementary to those with other incretins and the insulinotropic effects of glucagon-like component of the overall salutary effect on the glycemia. And this is something which I wanted to show. And the metabolic surgery, bariatric surgeries, of course, there are 3 types. There are remission associated with LGB is the highest among all these 3. And of course, finally, the optimizing weight management in people with diabetes would be permission, talk to your patients about their weight, understand the cause of obesity, look at the barriers, avoid the stigma, explain the importance of weight management, the advantages, what they get. And decision making has to be sharing basis, it has to be bidirectional, motivational interviewing, set realistic goals, don't try to jump into conclusions, and don't set the patient up for multiple cycle of failures and escalate treatment and consider the use of pharmacotherapy. And this is just to show you the future directions with the obesity molecules. Plenty of them. The PYY is something which is going to come up, the amylin agonist, and of course the GLP and glucagon agonist also people are trying. And the GLP, GIP, glucagon is a very promising, at least the weight loss, 15% and beyond is 84% of the patients have lost. Thank you very much for patient hearing, and any questions I'll be very happy to answer.
Thank you, Dr. Srinivas. Actually, you have got an interesting practice of studying the drug before you introduce to your patients. You have got a passion and also lucky to do that all. And now we call upon the next speaker, Dr. C. Muralidharan, who needs no introduction. He is the MGR for our conference. Of course, he is the secretary for our Tamil Nadu RSSDA, and he has a list of long thing to be introduced. He is the task force member for India Med Study, visiting faculty on Annamalai University, faculty insulinization for Indian program, mentor, nurses insulin education, and it has a long. But you all know about him. He needs no introduction again. Over to you, sir, on the topic, will CGMS replace HbA1c in glycemic management?
இனிய காலை வணக்கங்கள். Happy morning to all of you. Very happy to be a part of this organizing committee. First, my kudos and congratulations to Professor Anand Moses sir, friend Shanmugam, Chandrasekhar, Paneer sir, Dr. Pushpa, Mohan, Periyandavar, entire team worked effectively to bring out this conference, a wonderful one. Kudos, give a big round of applause to the organizing committee. Will CGM replace the HbA1c in glycemic management? It is not faith in the technology. It is a faith in people that makes the technology useful. So we have been using SMBG, HbA1c, CGMS. All these are important tools in the glycemic management, in the diabetic practice, for the glucose monitoring. Yesteryears, what we were using. Today, what we are using. Tomorrow, what we will be using. I hope doctors in this forum, more than 30 years of practice, you will appreciate. Diabetic management dependent upon urine sugar testing some 30 years before, 1980, 85, even up to 90. In places like Dindakal, suburbs, urine sugar testing, Benedict solution. So with the one value, 1 plus 2 plus 3 plus we are using, giving in treatment. Then we started using sugar testing, single test. Sometimes patient used to come, give the blood sample for the blood sugar. He comes after 15 days to collect the report. Those are the days. Now it is gone. So Benedict solution, urine sugar testing almost gone. We have been using glucometers extensively. Cost is very effective. And acceptance for HbA1c test is okay now. And some of our friends are using CGMS. My experience with the CGMS is limited. Hardly 2 to 3 patients in a month. That too, some of the companies are helping for the poor patients at free of cost. Some patients I am using as a paid one. Patient whom I come across with the CGMS on my own practice, it is very, very beneficial. But we want to know whether the CGMS will take over HbA1c or SMBG. கல்வியா செல்வமா வீரமா அப்படிமாங்க எது மூணுல எது முக்கியம் மூணுமே முக்கியமா let us wait and see. Triangle of diabetes care, optimizing, managing the overall glucose levels, minimizing the hypoglycemia, limiting the glucose variability. When you take up this HbA1c, it fails to detect glucose variability and hypoglycemia. Hypoglycemia is under-recognized with these tools, whereas our HbA1c provides a reasonable data on overall glucose levels. SMBG with the inaccurate monitoring may not provide adequate glucose data, whereas all these 3 parameters components are covered by CGMS. HbA1c was introduced, discovered in 1968. In 1989, HbA1c was part of the ADA standards of care. A1c targets are based on the interpretation of the DCCT and AQPDS. HbA1c is a good parameter of glucose control which can predict the occurrence of diabetes-related complications. Friends, many of our patients, motivated patients, they do SMBG, depending upon the situation, 3 times a day, 4 times a day, 5 times, 6-point testing, all those things. Even the frequent testers often miss significant glucose fluctuations. Left-hand side, right-hand side, both are same patient. Glucose testing 24 hours using the glucometer. Right-hand side, CGMS. So, when you do the CGMS, we could come across that lot of missed highs and lows. Blood glucose results offer only a static picture of at any point of time, and they do not provide a sense of the number, intensity, and the duration of the glycemic excursion. To simply say, blood glucose result offers a static picture at any point, like a still camera, whereas CGMS evaluates glucose levels continuously and provides a sense of the number, intensity, and the duration, like a video camera and movie camera. Yes, fluctuations in the blood glucose, we know it is harmful. What are the consequences? Increased risk of hypoglycemia, hyperglycemic episodes, risk of micro and macrovascular complication, and impact on the psychological well-being and quality of life. Yes, this slide you would have seen in many forums. 2 patients, similar HbA1c, different phases. One patient with the high GV, another patient low GV. Again, this is a new concept, time in range with the CGMS. 7% HbA1c considered to be as a normal HbA1c for most of the patients, but the same normal 7% HbA1c, 3 type of patients, see extreme, third patient 100% time in range, second patient 70% time in range, first patient 40% time in range, and 40% time above range. So we want our patient to be in the third or second level. So HbA1c alone does not give the good indicator of the glycemic control. And patient and friends, you will appreciate, most of the times we come across patients with the normal, with the elevated HbA1c, but normal fasting glucose and 2 hours glucose. Sometimes we come across patients, normal HbA1c with the elevated blood sugar levels. So HbA1c 7.1, fasting plasma glucose 236, postprandial 261. See, imagine today we are in the conference. In the last 2 days, we consume high-calorie diet. Imagine our patients attending a marriage function, consuming a high-calorie diet. So, sugar levels are elevated. He report the doctor on Monday, levels are elevated, whereas his HbA1c is normal. So, HbA1c is misleading in most of the patients, in most of the situations. So, for which we need to educate the patient, we need to use our clinical knowledge to assess all these things. There are limitations of HbA1c. HbA1c alone to guiding the improvement in the glycemic target, not optimal. A1C remains a key indicator of long-term diabetes complication, people with the type 1 and type 2 diabetes mellitus. A1C does not reflect hypo and hyperglycemia, fails to identify the magnitude and the frequency of intraday and interday glucose variations. It does not reflect the short-term changes in the blood glucose. Conditions like anemia, hemoglobinopathies, iron deficiency, pregnancy can confound A1C measurements, leading to inaccurate measurements of mean glucose. Ethnic variations also occur. Yes, long-term use, 1% reduction in the HbA1c, reduction in the complications, both the microvascular and the macrovascular complications, and the utility of A1c is enhanced when used as a complement to the CGM data. Friends, the sensor-based glucose monitoring provides the ability to assess the glucose variability as well as identify the patterns and trends of the glucose. Why do we use CGM? Yes, CGM uses the proactively manage the high glucose and low glucose levels and added insight which impacts, help to find out the impact of the meals, impact of the exercise and the illness on the blood glucose levels. By doing this, by assessing this, we can modify the therapy. What is time in range? Time in range refers to the percentage of time that the person with the diabetes spends within the target glucose range or above the range or below the target. So, what is the carry-home message here? The primary goal for effective and the safer glucose control is to increase the time in range while reducing the time below range. What is the clinical importance of TIR? Gives immediate information about the current glycemic picture, so appropriate therapy adjustment we can do. Main carry-home message is TIR more actionable than HbA1c alone. Data shows a relationship between the TIR and HbA1c, and it correlates with the risk of diabetes complications. What are the benefits of TIR? TIR and A1C are inversely related. Based on the type 1 diabetes and type 2 diabetes studies, every 10% increase in the TIR shows 0.8% reduction in the A1C. 70% of the target correspond to the A1C goal of less than 7%. And above all, TIR is a valid metric for both acute and long-term glycemic control. So, time in range, importance, benefits in the microvascular and macrovascular, 10% reduction in the TIR, 64% increase in the retinopathy, 40% increase in the nephropathy, and 10% increase in the TIR, 6.4% lower risk of abnormal carotid intima media thickness. ADA recommendation, the sensor-based glucose monitoring system can generate AGP reports that include percentage time in the plasma glucose ranges, AGP, a visualization of the aggregated glucose patterns from the report period, daily glucose profiles you can get for the report period. So, TIR and the AGP report facilitate the development of safe and effective care plans for the patient with the diabetes. And decreased TIR, I told you, long-term complications, nephropathy and the retinopathy. TIR may be the surrogate marker for all-cause mortality, and it is a potential measure of therapeutic success. Now, we want to know A1C or CGM for management. See, 3 different patients, all 6.7% HbA1c, very good control. But when you see the CGM, see first patient, 83% TIR, 1% hypo, glucose variability 26. You see the third patient, glucose variability 53%. We don't want our patient to experience glycemic variability above 50% or 53%. See the third person patient, time in range only 53%, 51%. So we want our patient to achieve the HbA1c control, and also we want our patient to maintain the TIR above 70% and maintain the TBR below 4 or 3 or 2 1%. And we want our patient to reduce glycemic variability. And ADA recommendation, yes, time in range is a new metric of glucose control beyond A1C. And there is a new concept, time in tight range. Professor Thomas has introduced. What is the difference between the time in range and the time in tight range? Only one thing. Time in range, blood sugar levels are 70 to 180 milligram percentage. Time in tight range, 70 to 140 milligram. Time in pregnancy range, 63 to 140 milligram percentage. And all the international diabetes societies, they endorse the use of TIR in addition to A1C. And Indian TIR consensus recommendation advocates TIR as a powerful metric for glycemic control. What are the advantages of the CGMS over HbA1c? Very, very important slide. Real-time glucose data, CGMS provides current glucose levels, but HbA1c average level. Detailed glucose profile, CGMS shows glucose patterns and trends. HbA1c only provides a single value. And hypoglycemia detection possible with the CGMS, glucose variability possible with the CGMS, timely treatment adjustments, improved patient engagement, improved enhanced diabetes management, detection of glucose spikes and dips, whereas CGMS offers individualized glucose data, while HbA1c is a standardized measure. CGMS offers a more detailed and dynamic understanding of glucose control, enabling more effective diabetes management and treatment decisions. And friends, there are some advantages of HbA1c over CGMS. HbA1c is convenience, simple blood test, cost effective, standardization, long-term trends, no calibration needed, wide availability. Now we want to know, conclusion, take your message. Measurement of HbA1c is still a gold standard test, no doubt in it. But limitations. TIR is a key metric of the quality of the glucose control. The idea of TIR has challenged the conventional viewpoint of using the HbA1c as a one-size-fits-all monitoring tool for DA management. Evidence is beginning to emerge linking the lower TIR to increase the risk of long-term diabetes complications and adverse pregnancy outcomes. CGM should be mentioned as the TIR and detects within the day and the intraday, the interday glycemic variability, which may enhance patient self-management of diabetes. Finally, more randomized trials are needed that study the relationship between the glucose variability and the hard endpoints like retinopathy and nephropathy. So, will CGMS replace HbA1c? Friends, CGMS and HbA1c, they complement each other. And CGMS is not intended to replace, one more minute. CGMS is not intended to replace HbA1c entirely. Instead, CGMS can provide additional insight and enhance glucose management, while HbA1c remains a valuable tool for diagnosis, long-term monitoring, and standardized comparison. The future of diabetes management will likely involve a combination of both the CGMS and HbA1c, even the combination of SMBG also, leveraging their respective strength to provide optimal care. So, use both. One cannot replace the other at present. So, Kalviya, Selvama, Veerama, Edu Venum Ketta, Moonume Venum. As on date, we need SMBG, TIR, CGMS and HbA1c, and we need to motivate, educate our patients. First, they have to do the test. Many patients, they are reluctant to do the test. We have to advise them to do fasting 2 hours at least once in a month, once in 3 or 6 months of HbA1c. Depending upon the patient situation, we have to encourage our patient to go for CGMS regarding type 1 diabetes patient, type 2 patient on insulin, hypoglycemia unawareness, and pregnancy patient. So depending upon the situation, we need to decide whether this is okay or this is okay, or we need to combine everything. Thank you very much for the patient listening. Welcome to RSSDA 2024 at New Delhi. Block the dates. And 4th research retreat at 2025, 1st and 2nd March 2020 in Madurai, Grand Hotel GRT. And our Dr. Shanmugam sir and the entire team is organizing. So we wish you to submit your abstract and block the dates. Thank you very much.
Thank you, Dr. Murali. He elaborated nicely the pros and cons of HbA1c and the advantages of continuous glucose monitoring. The next speaker is none other than our Dr. Chandrasekhar. He needs no introduction. He is an important personality in the API circle, and he is the co-scientific chairman of TRAC. And the topic is DPP-4 inhibitors and sulfonylurea in type 2 diabetes, strategies to maximize the patient impact. Over to you, sir.
Yeah, today I'm going to dwell on the next 15 to 20 minutes on the exploring the strategies to maximize the patient impact of DPP-4 inhibitors and sulfonylurea. This is my flow of presentations. First, I'll begin with the how we can elaborate on choosing a suitable pharmacological agent for the diabetes management. So we all know that whenever a patient is diagnosed with diabetes, the lifestyle measures or rather the modifications are the important thing that has to be considered with the initial diagnosis of diabetes. But because of the intricate nature of the diabetes, there is a gradual decline in the beta cell dysfunction. And as a result, we all know that the lifestyle measures alone may not be sufficient to maintain the adequate glycemic control over a period of time. Naturally, we need to implement some strategies to involve some therapeutic measures to get the glycemic target under control and to maintain it. Now we have some guidelines. Of course, these are all the guidelines which are stood the test of time. We all know that, what ADA says, AS says. So all the guidelines, they again endorse the importance of lifestyle modifications at the initial onset of diagnosis of diabetes. Of course, AS has gone one step ahead and saying that if patient is able to achieve a considerable weight loss, they would be able to retard the progression of the diabetes. So that's what it says. But again, as I already alluded to, the lifestyle measures alone may not suffice, and we need to add some therapeutic changes. Put together a therapeutic drugs and the lifestyle measures, it was demonstrated that it was able to retard the progression in more than 40% of the cases. Now let us see the combination therapy. So the combination therapies are the order of the day. Previously we used to have the traditional method of treating diabetes in a stepwise manner. So we add one after another to metformin, and there are some advantages also we add. So we try to find out the positive and the negative effects of the drug tolerance, of course, the compliance, cost, all these things were matters. But now we have come to understand that diabetes is a systemic disease, wherein there are multiple pathophysiological factors operating in it. So we need to address all these, the pathophysiological factor, and the order of the day is to start the patient on the combination therapy whenever you find any patients with HbA1c more than 1.5 to 2% above the target. I think this is a very common algorithm, we all know that. Along with the lifestyle measures, if somebody is on metformin, if they fall short of achieving the glycemic target, I sensitize the patient with insulin. When they shortfall of insulin, for shortfall of reaching the glycemic target with metformin, we usually sensitize them for insulin, either a basal insulin or a short mealtime insulin. Many times our patients, they will be hesitant or they may say some reasons for their, due to their occupational issues. Then we have to resort to a combination therapy along with metformin, commonly with sulfonylurea. But we do have now plenty of choices. In addition to the metformin, we have DPP-4 inhibitors, SGLT2 inhibitors, oral GLP-1 receptor agonist. All these combinations are now very much available, and we do have some substantial evidence also. Let us dwell into the dynamics and the evolving landscape of the diabetes management. So what are all the goals we all know? I think it's a very familiar slide. The guidelines recommend the fasting to be maintained between 80 to 130 and postprandial, preferably less than 180 milligram per deciliter, and HbA1c of less than 7 is preferable. Of course, it all again starts with lifestyle measures and metformin, and we need to keep adding the drug. But now the scenario has changed. So we are celebrating World Heart Day today, 29th of September, and we look into all our patients are potentially at risk of developing a cardiac problem, renal problem. We look at not only our focus is on these numbers, fasting, PP, HbA1c, but our focus is slowly shifted to focusing on the cardiovascular outcomes, the renal outcomes, the risk of hypoglycemia, the impact on weight, the patient's tolerability, safety profile, all these things like we started looking at, and now it has become a multi-dimensional approach where we need to target whether the patients are having any comorbidities like ASCVD or CKD, and preferentially like we may have to start the patient on GLP-1 receptor agonist or SGLT2 inhibitors. Of course, we are going a little bit ahead, and now we focus on the pathophysiological changes also, like obesity, and we try to bring down the weight loss. And if the patient is able to reach a significant weight loss to the tune of 10 to 15%, they may enjoy the remission also. So this is where our focus has now shifted, and it has become a multidimensional, and patient needs to be on metformin with a combination therapy. Of course, the lifestyle measures, the regular physical activity, the good nutrition, good quality of sleep. Yesterday we had the oration from our chairman, Dr. V. Rajendran, who emphasized the importance of sleep. So sleep and of course the smoking cessation, all these things, they forms the foundation for the lifestyle measures. Of course, every patient's like we need to make some attempt on the management of overweight and the obesity as well. So now let us see the issues and challenges which we face with sulfonylurea. Of course, this is the very commonly advocated drug after metformin. We all know that. But what happens is we lack uniform recommendation, whether it is a national or international guidelines, like we lack. Where do we place this sulfonylurea? Where are we now? So we have been using this sulfonylurea in combination with metformin, either alone or as a FDC. FDCs are very simple, easy to prescribe, and the patients are able to get good good number of reduction on the blood parameters, fasting, postprandial, HbA1c, and so on. And of course, the patients were able to tolerate better, and it offers convenience also, and it's cost effective. But remember that it is happening at the risk of developing a hypoglycemia and possibly a weight gain also. Every time when a patient is put on FDC in our clinic, whenever a patient on FDC comes to us, like we really look into the symptoms suggestive of the risk of hypoglycemia, or possibly whether the patient had a minimal hypoglycemia or not. And accordingly, we need to change our strategy. So this is the state of affairs, but we face it with the sulfonylurea, particularly the FDC combinations. Of course, there are some guidelines, the International Task Force, particularly aiming at the low and middle income countries of the Asia and Africa. They have put forth some guidelines. We can use the sulfonylurea, of course, the modern sulfonylureas like glimepiride, glyclazide, and they are going to stay with us, and they are going to make a good impact on the glycemic control. Of course, like these patients on metformin, in addition to the sulfonylurea, now we have some preferable alternative to sulfonylureas also. Say, for example, we have DPP-4 inhibitor, SGLT2 inhibitor, and of course, insulin also. So now we have some therapeutic options in the armamentarium to treat patients with diabetes. Now let us move ahead to focus on the role of these DPP-4 inhibitors in the treatment algorithm of the diabetes. We have been using these DPP-4 inhibitors for quite some time, more than 1.5 decades. We have got a rich experience with the DPP-4 inhibitors. They are the good group of drugs like that can gel with any drug for that matter. The easy of use, convenience, and it offers good glycemic control, of course durable control with minimum risk of hypoglycemia, and they are weight neutral. And once the patient is started on, many of our patients, once the patient is started on DPP-4 inhibitors, that's the thing, like no need to up titrate or low down titrate, except in few situations, like of course linagliptin, we have linagliptin also, where we can use liberally on patients with the CKD also. So what are all the potential other advantages? We can use this, the DPP-4 in the frail individuals, particularly in replace of sulfonylurea. So these patients are the vulnerable people who can develop hypoglycemia. Of course, they are weight neutral, and renally impaired patients also, like some of the gliptins, like linagliptin, have got a role to play. And of course, whenever we see a patient who is at risk of hypoglycemia, I think the DPP-4 inhibitors have come here, a handy choice of therapy in addition to the metformin. I think it is also endorsed by our RSSDA guidelines as well. No talk on DPP-4 inhibitors would end without mentioning this, the CV safety study, the TCOS study. We all know that it was a revolutionary study, but of course it came after that Savertimi fiasco with saxagliptin published in 2015. So it was a large randomized study involving 683 sites in 38 nations. More than 14,000 patients were recruited. Very simple. One arm, the patients were put on the standard of care treatment. In another arm, like in addition to the standard of care, the patients were given 100 milligram of sitagliptin. And they were assessed for MACE, CV death, non-fatal MI, non-fatal stroke, and hospitalization for the angina. And we have got some secondary outcomes also in the form of hospitalization for the heart failure. What happens? The DPP-4 inhibitors did not significantly increase the cardiovascular rate. So as a result, the key conclusion from the TCOS study, ladies and gentlemen, in patients with type 2 diabetes and established cardiovascular disease, the addition of sitagliptin to the usual care did not have any significant effect on the rates of major adverse cardiovascular events or hospitalization for the heart failure. Now let us see what are all the available evidence or advantages of the DPP-4 inhibitors over sulfonylurea. This is again a population-based study, a small study. The DPP-4 inhibitors have got, when compared to the sulfonylurea, have got, this is a followed-up period of 9 months, and they were able to show significant changes in the urine albumin-creatinine ratio also. And there is yet another study. Usually we put the patient, this is a population where the patients were newly recruited patients, where they were put on sitagliptin, and in one arm, except DPP-4, excluding linagliptin, and in another arm, they were put the patient on the glycoside, 30 milligram and higher dosages. And they were able to assess the efficacy of these two arms on the fasting blood sugar, the HbA1c, the overall body weight, and the systolic blood pressure, where the DPP-4 inhibitors were able to show substantial reduction on those parameters. Now let us go to again, what are the available evidence of the advantage of these DPP-4 inhibitor over sulfonylurea as an adjunct to metformin. So this is a study, quite interesting study, again a non-interventional, multicentric study, where the patients were grouped into 4 categories. The patients were receiving metformin alone, metformin with glimepiride, and glycoside with metformin, and another arm, the patients were put on metformin with the sitagliptin, where they were able to show, all these patients were like newly detected patients. They have been followed up for a period of 1 year, and they were not having any serious complication or comorbidities. What they observed is the frequency of emergency visits and hospitalization due to hyperglycemia in the DPP-4 groups were far less when compared to the people who have received metformin with sulfonylurea. So this is a very important thing, because we do see many patients admitting with uncontrolled hyperglycemia in the emergency department. So this is again another quite interesting study where it has shown that the people were put on the population-based cohort. This is taken from the electronic medical records, where they were able to demonstrate the efficacy and the durability of control of blood sugar after 5 years. Again, the patients were randomized to have metformin, sulfonylurea, TZDs, and DPP-4 inhibitors. And the people who were in the DPP-4 inhibitors, they were able to demonstrate a durable control of the glycemic control. So this is again a population-based study done in the Korean National Health Insurance, the service health screening cohort, where they have taken more than 5 lakh individuals, and again they were randomized to see whether the patients were, the endpoints were whether the patients had any MACE, 1 minute, MACE, and the requirement for renal replacement therapy. So in this study, it's a huge population-based study. In fact, it's a real-world evidence to show that a DPP-4 inhibitor does not appear to increase the overall risk of major CV and renal outcomes. Ladies and gentlemen, in summary, the lifestyle measures are the initial cornerstone of the treatment of successful diabetes management. And of course, now we need to prioritize drugs along with metformin, so that has got a favorable outcome on cardiovascular and renal safety. Of course, DPP-4 inhibitors have shown a significant control on the fasting blood sugar, postprandial, of course, overall HbA1c, and particularly the sitagliptin has got in addition, the beneficial role of preserving the beta cell function. And the addition of the metformin with the DPP-4 inhibitors have shown improved medication adherence and increased duration before discontinuation. So with this, I end my presentation, and happy for being a wonderful audience. Thank you.
Thank you, Professor Chandrasekhar. Yet another excellent lecture here. The floor is open for the entire session. All the 3 speakers will be ready to respond to that.
My question to Professor Dr. Srinivasa Murthy, it's very simple. I would like to know your observation, findings on weight reduction potential of tirzepatide versus cagrilintide and retatrutide. That is based on the limited data available.
Thank you, sir. I think in the order, it is retatrutide, tirzepatide, semaglutide. CagriSema is just started, sir. The Reimagine 2 is just started. So I don't think we have, but tirzepatide, retatrutide is retatrutide, no doubt. 3 months, there are people who lost about 20 kilos, 25 kilos. 3 months. Lot of diarrhea. Lower GI is more with the retatrutide, what we have seen. Tirzepatide, the upper GI, bloating, vomiting, nausea, etc. So this is 2 things which we can know. Reimagine is just started, so I don't think we have any data to compare. Because by and large, though it will be blinded studies, most of them are double blind. But we will come to know because of the adverse events in most trials. Up titration weekly to 15. Yeah. The maximum dosage is 15. But somebody doesn't tolerate, you can down titrate and maintain at that time.
So you go for 50 for all, or if you see some response, you retain at that stage?
No, ma'am. Everybody has to be, it's a protocol driven, right? So protocol, you need to up titrate everybody. If doesn't tolerate, if there is withdrawal, criteria will be there. So then you can withdraw also if safety is a concern. For example, if somebody has got 20 times diarrhea per day, then I don't want him to continue, example. So you can withdraw, but you need to document all that. That process is there. But you have to up titrate, that will be a protocol, to the maximum dosage or maximum tolerable dosage. then I have to give explanation if somebody I am stopping at 10 mg. Example, I don't want him to go to 15 mg. I can write. It's called principal investigator's discretion, PI discretion, where I have to comment and say, this patient I'm holding on 10 mg for so and so reasons. That can be
And
done.
again, the response is it individualized, differs from patient to patient, or you definitely get a weight gain?
I think what we have seen in trials is the more the BMI, the better weight loss. It's same rule. More the HbA1c, the drastic fall will
Response
be
is
less. Yeah. Definitely, sir. Definitely it is there. Sir, that is what? It's an anti-diabetic therapy means you need to continue, right? You continue your SUs, metformin. So you continue this as well. That is the message. It is not to just to weight loss and then bounce back.
When achieving the weight loss, I am very confident of my lifestyle modifications. Certain weight loss I have achieved, then I stop it. Can you maintain it with my lifestyle modification?
No, sir. I don't think you can maintain to the tune of what you have lost. Physiologically, there will be regain, right?
That's a yo-yo phenomenon, like
Sir,
that should not be done. Sir.
Lifestyle modification. We are talking about decades. For nearly 30, 40 decades, we are talking lifestyle modification. In practice, practically I'm talking you, sir. Is it really possible in your patients to lose at least 5% of the weight loss over a period of time?
Yes.
No, I'm just asking,
In a
because-
handful patients.
That's
would
what
say
I
in
meant,
handful patients.
because you are showed the records as 8% or something. So practically, it is said, but difficult to adopt it.
Agreed, sir.
And regarding all the molecules said, it's pretty costly. We can't afford in a country like ours. Even for semaglutide, it costs you $10,000 per month. So still, we have to talk about more on the diet part of it to change the mentality of the patient rather than the molecule. Molecule is not going to give you a better benefit, sir. That is my contention.
Agreed,
Because
sir. Agreed.
we are not like America where the government pays it. The
Thank
next
you, sir.
question is to Dr. Muralidharan.
Thank you, sir. For want of time, the organizers want to close the session. Thank you all. If you have any further doubt, you can contact the persons and get your doubts cleared.
Thank you, sirs and ma'am. Thanks for the wonderful session. We request the chairpersons to present the mementos to the speakers. We request Dr. Muthuselvam to present the memento to Dr. L. Srinivasa Murthy, sir.